أسعد الله مساءكم وأهلا بكم في محاضرة هذا المساء، وهي بعنوان Psychosis and Antipsychotics. يقدمها الزميل الدكتور محمد أمين الحيحي، مستشار الطب النفسي في المملكة المتحدة. تفضل دكتور محمد.
شكرا دكتور وليد. فعلا يسعدني أن ألتقي بكم وشكرا جزيلا للدكتور وليد على هذه الفرصة ويسعدني فعلا أني أكون متواجد معكم أو لنعترف جميعا بالجهود القيمة اللي يقوم فيها الدكتور وليد بالنسبة لأهلنا في الأردن في تطور الطب النفسي. أم، أنا لست فعلا لا محاضر في جامعة ولا أستاذ، ولكن خبرتي من خلال السنوات العمل هذا الموضوع شد الانتباه بالنسبة لي من البداية، فبحب أشارككم هذه التجربة. أم، كيف هلا بدنا نمشي؟ آه. بديت عملي في الطب النفسي في الكويت بعد تخرج من جامعة بولونيا. انتهيت في الكويت عند الأهل طبعا، وخلال عملي كنت طلع بيان في الجريدة إنه الدكتور فخر الإسلام بده أطباء اثنين جداد على الطب النفسي، ما كانوا يعرفوا شيء في الطب النفسي، وبده هو يشتغلوا معه في كلية الطب في جامعة الكويت. فأنا قدمت طبعا، وزميل آخر كان معي، واشتغلنا في الأكاديميك يونت في الجامعة مع الزملاء الآخرين. الحقيقة أني تعلمت مبادئ الطب النفسي على يد الدكتور محمد فخر الإسلام، وهو أستاذ وعزيز فعلا وقيم، والأشياء اللي تعلمتها منه ظلت في حياتي من خلال عملي لما جيت على المملكة المتحدة في بريطانيا. طبعا زي ما بتعرفوا الدكتور فخر الإسلام كان له بحوث كثيرة في موضوع الانتر جنريشنال كونفليكت، وعمل ريسيرش كبير حول الريليشن شيب بين البيرنتس والتشيلدرن، أو ال السكند جنريشن في دول زي الكويت وقطر بعد ظهور البترول أو الأويل، كتطور في البلد. واللي حصل إنه طبعا كان في هناك موضوع كيف إنه التطور حصل في الكويت من خلال الطب النفسي. وبذكر أشياء كنا نعملها إحنا في الطب النفسي في الكويت في هذه السنوات، في بداية أو منتصف الثمانينات، إنه كنا نعمل الورد راوند، نعمله خارج المبنى. فكان مستشفى الطب النفسي طبعا غير الصورة اللي موجودة حاليا، من بقايا الجيش الإنجليزي اللي كان مسيطر على الكويت في هذه المنطقة في هذه المرحلة. فكان في بعض الأشجار في المنطقة، كانت الحلوة المنطقة. فكنا ناخذ المرضى ونقعدهم ونعمل معهم الورد راوند. ففي أحد المرات جذب انتباهي إني وإحنا برا إنه شفت في بيرد، عصفور كان ميت على الأرض. فطبعا عصفور ميت، مشيت بعد شوي لقيت كمان عصفور آخر ميت على الأرض. فطبعا أنا من خلال عملي في لي علاقات مع النيرسينج ستاف اللي كانوا موجودين. بذكر أحمد مناع كان وورد مانجر هناك. فجيت له فأقول له: يا أحمد، شو الموضوع في عصفور ميت على الأرض؟ وبعد شوي شفت عصفور ثاني. شو الموضوع؟ شو اللي بصير؟ كيف هاي العصافير بتموت هون؟ قال لي: ما عرفت. قلت له: لا والله ما عرفت، تحكي لي. واللي بيقول لي أنتم بتصرفوا الأدوية للمرضى، الكلوربرومازين والثيوريدازين والريسبيريدون، بتعطيهم للمرضى، المرضى بحطوهم بتمهم، بيطلعوا برا بكبوها، فبيجي العصفور بياخذها، باخذ الحبة بطير فيها، بعد 5 دقائق 10 دقائق بيطلع بنزل العصفور ميت. فهذا شدني الموضوع فعلا، إني أنتبه لحكاية الأدوية. طبعا إحنا كل أهميتنا كأطباء إنه نحمي المريض وما نشكل أي خطورة على المريض، لكن إنه عصفور بيموت معناته في أذى كمان على الإنسان نفسه. فطبعا أنا انتقلت بعد 3 سنوات خبرة في الكويت، انتقلت إلى بريطانيا، وهذا هو المستشفى اللي اشتغلت فيه أول ما وصلت. كان اسمه رين هيل هوسبيتال في ميرسي سايد، قريب من ليفربول طبعا. وهو كان هذا المستشفى من أقدم الأسايلمز في اللوناتيك سايلمز كانوا يسموهم في هذه الفترة في في يوروب. كان في حوالي 3000 بيشنتس موجودين فيه، وكانوا كوميونيتي، يعني يعيشوا ككوميونيتي. كانوا المرضى يعملون ويشتغلون ويعني يعملوا خضروات كمان، يزرعوا ويبيعوا للكوميونيتي الموجودة حواليهم يعني. فبذكر إنه كان في أحد 1 يوم في الأسبوع كانوا يعملوا سينما كمان، والناس تيجي وتتفرج مع المرضى. خلال عملي هناك كمان شفت في بعض المرضى اللي فعلا ما شفتهم بعدين، مثل ناس عندهم لوبيكتومي، يعني كانوا أواخر اللي عملوها في الخمسينات أو أوائل الستينات في هذيك الفترة، كانوا موجودين في هذا المستشفى. طبعا ما كانوش يتكلموا هذول المرضى، ولكن كان البيهيفير تبعهم والمانرزم كان اتراكتنج، يعني مشان الواحد يتعرف عليهم أكثر. كمان بذكر شفت عدة حالات لناس كانوا أنونيمس، يعني بذكر إنسان كان من لاتفيا، وهذول الناس كانوا من بعد الحرب العالمية الثانية، اللي ضاعوا بين الحرب، يعني بين بريطانيا وفرنسا. وصلوا لبريطانيا وحطوهم في المستشفيات، لكنهم ما كانوا يذكروا their identity ولا their أسمائهم. يعني طبعا هدول most likely they suffered shell shock syndrome، أو اللي احنا بنسميه PTSD. تماما. طبعا هون احنا لما نحكي عن الانتي سايكوتكس لازم نذكر السايكوسيس كمان في نفس الوقت. في البري ساينابتيك والبوست ساينابتيك الدوبامين بيكون اكسس اوف ذا دوبامين، اللي هو بيسيطر على الموقف طبعا من ناحية الايتيولوجي اوف ذا سايكوتيك سيمتوماتولوجي. طبعا احنا بنعرف الدوبامين هو الموست امبورتنت نيورو ترانسميتر في البرين في الهيومن beings. They are responsible for functions: thinking والcognitions والfeelings والmotor movements. لما يكون في excess of the dopamine الباثواي بتصير disturbed، فهون بتصير موضوع البوزيتيف سيمتوماتولوجي من الديستربنس في الميزوليمبيك باثواي، والنيجاتيف سيمتومز بتصير من الكورتيكال ميزوكورتيكال، والنيجروسترياتال سيستم بيؤدي الى الاكسترا بيراميدال سايد افكت والتاردف ديسكاينيزيا اللي ممكن نحكي عنها بعدين. والتوبروفيندبولار باثواي بيكون مسؤول عن one of the main side effects of these excess of the anti excess of the dopamine اللي هي الهايبربرولاكتينيميا. طبعا من خلال دراستي في الطب جلب انتباهي كمان لعدة ناس أساتذة في الطب النفسي. بذكر الدكتور طبعا زاس من نيويورك، اللي هو أسس الأنتي سايكاتري موفمنت. طبعا هو أسس الأنتي سايكاتري موفمنت بناء على برنسبلز في his life يعني وhis thought. He challenged the psychiatric diagnosis يعني. والvalidity of the mental illness in itself. He was highly critical of the asylum system في USA في هذاك الوقت، وكتب كتب كبيرة يعني عن الانتي سايكاتري. The other one is Ronald Lang. He is Scottish. He worked in London. عمل series of programs على البي بي سي. السايكوسيس بالنسبة له كانت هي failure in the family function. ومن أحد الأسباب اللي جعلته ينتبه إلى هذا الموضوع هو الباك جراوند تبعته. He comes يعني from a very dysfunctional relationship with his parents, and he spoke a lot about this problem يعني. فبالتالي he intended to analyze the psychosis based on the relationship between the human being and the close members of the family. لما كنت أدرس طب في بولونيا في إيطاليا في أوائل السنوات الدراسية، كان في بعض الطلاب أكتيفيست، يعني يجوا قبل المحاضرة يوزعوا ليفلتس. فأحد الليفلتس كان اللي انتبهت لها اللي هي كان اسمها بسيكياتريا ديمقراطيكا أو ديمقراطيك سايكاتري، اللي هو طبعا فرانكو بازاليا كان leader of this movement. طبعا he challenged the government attitude towards mentally ill patients. He identified that these people, they are marginalized in the community, and they can't vote, they have no rights in the community, and he fought to close the asylums. And he managed all his life to fight for that kind, revolutionize the the psychiatric service in Italy, and he created a law called Law 180. طبعا فرانكو بازاليا توفى، فابنه لحد الآن يعني he is كمان working towards the program of his father. طبعا كلنا شفنا هذا الفيلم One Flew Over the Cuckoo's Nuts. طبعا هذا الفيلم attracted the attention of the whole world. يعني جاك نيكلسون played the كاريزما في الموفي، وكان طبعا هو الباك جراوند based on anti personality and anti social personality، ولكن كان بارع في انتباه الناس للي بيصير في المستشفى، خاصة موضوع الأدوية يعني اللي بنتكلم عليها، كيف إنهم المرضى كانوا يأخذوا الأدوية وبعدين يروحوا يرموها، وبعدين العلاقة مع البيشنت والنيرس، كيف إنه موضوع الأدوية يصرف للمرضى، والمريض طبعا كان بعضهم يمثلوا إنهم مريضين، وبالنهاية كانت النتيجة سيئة جدا، يعني إنه بعض المرضى committed suicide. في أحد الأنوال جنرال كونفرنس للرويال كوليج أوف سايكاتريست كان في إدنبرا، كان في مظاهرة زي ما بتشوفوا حضراتكم، كانت سايكاتريك كيلز طبعا ضد الأدوية، وكانت الشرطة كمان تحمي المتظاهرين نتيجة نتيجة المؤتمر اللي كان جنب في أحد الهوتيلز قريب يعني. طبعا احنا لازم هلا ننظر لموضوع ليش هدول الناس بيحكوا على الانتي سايكوتكس انهم بيأذوا المرضى. هناك في عدة مواضيع طبعا. Is there any evidence that the antipsychotic medication can cause harm to the patients؟ طبعا زي ما بنعرف انه السايكوسيس they are excess of the dopamine بيؤدي الى السايكوسيس. كمان blocking these kind of dopamine بيحسن من الوضع وبنورماليze it. احنا بنعرف انه الانفيتامين، الناس اللي بياخذوا الانفيتامين زي سبيد مثلا ولا الانجل داست بينتهوا في موضوع بارانويد سيمتوماتولوجي. فهاي الأدوية، هاي الإليسيت دراجز بتخلق نوع من أنواع الانكريز اوف ذا دوبامين اكتيفيتي. فبناء على هذا الموضوع ظهرت الثيوري إنه we can block the dopamine excess، بنحسن من وضع المريض. وهنا ظهر الحقيقة في أدوية اثنين ظهروا بالصدفة، يعني اللي هو الكلوربرمازين والريزربين. في الخمسينات أو في الستينات كانوا هذول الأدوية يستعملوا لأشياء أخرى. يعني الريزربين كان أنتي هايبرتنسيف، والكلوربرازين كان أنتي إميتيك يعني في هذاك الوقت، فاللارج أكشن اللي هو اللارج أكتين. فالسايد افكت من الأدوية هاي ظهر إنه الفايلنت بيشنتس تحسنوا، وكمان بعض البيشنتس اللي كان عندهم سايكوسيس خلال وعندهم associated comorbidity physical health problems تحسنوا على هاي الأدوية. فزي طبعا موضوع الاي سي تي في الإبليبسي، فصارت موضوع الريسيرش يبدأ حول موضوع الدوبامين activity in the brain والانتي سايكوتكس. الحقيقة إنه أنا لاحظت هذا الموضوع جيدا، يعني إنه مثلا لما يكون في عندنا مريض aggressive أو مريض withdrawn وفي marked يعني change in their personality، أهل المريض ممكن يتوصلوا إلى إنه المريض يدخل المستشفى. وحصلت يعني زي موضوع مثلا الكاتاتونيا، ينظر يدخل المريض المستشفى، بنبدأ فيه بالعلاج في الأنتي سايكوتكس. بنلاحظ إنه بعد يومين ثلاث أو أربعة تظهر الأعراض السايكوسيس، يعني بصير المريض يتكلم عن الاوديتوري هالوسينيشنز والديلوجنال سيستم اللي عنده. ففي بعض الناس يعني الكريتيكال اوف ذا انتي سايكوتكس بيقولوا هاي هي الادويه اللي ادت الى السايكوتيك سيمتوماتولوجي مش المرض نفسه. وهنا بتظهر طبعا التشالنج في الموضوع. الفارماكوتيكال كومبانيز طبعا لما بروديوس ا دراج they talk about the efficacy of the drug not the effectiveness. وهنا موضوع مهم جدا، يعني المرضى اللي بيختاروهم الفارماكوتيكال companies they are selected، فبالتالي الدواء مش ممكن انه كل انسان مريض بالاعراض هاي يتحسن على المريض. وهنا طبعا احنا بنعرف من اول clinical practice انه it's a valid theory. مشان هيك احنا بنشوف الدواء يعني بناء على drug effectiveness وليس الافيكاسي زي ما الفارماكوتيكال كومبانيز بيبيعوا الدراج يعني. او طبعا كثير من المرات احنا بنلاحظ انه المريض لما يجي او اهل المريض they ask for how long the patient needs to be on medication. And to be honest with you, sometimes we might give them an answer based on our experience, but there is no evidence that our response is always right. Sometimes for an acute psychotic episode, we might say up to 2 years medication. Some people, they might say 6 months. And we know young people who are students, they are very keen to stop or to discontinue their medication. فهنا بتظهر موضوع إنه والله إحنا مش فاهمين بالضبط شو هاي الأدوية بتعمل منشان إحنا نعمل recommendation للpatients. Can we identify the long-term protective factors of antipsychotic against relapse? Again, we always say to the patients and to their carers, we need to continue on this medication to prevent relapse or to attenuate the symptomatology of any relapse might happen. Again, we don't know how effective these kind of assumptions. We learned during our clinical practice the early warning signs of the relapse, and we depend sometimes to educate the patients and their carers based on these kind of evidence. Another critical point related to the antipsychotic medication, the cognitive decline, especially in schizophrenic patients. And we know that the chronicity of the illness in itself can cause cognitive disturbances. But some people, they might argue about this and they say, well, the antipsychotic medication, they are the cause of these kind of problems. There is a study, one of the first studies by WHO in 1969, where they showed the disparity in the outcome, and that after 6 months of taking the antipsychotic medication, what happened to this group of the patients. And they found that the people who are from developing countries, they do much better than the developed countries. And they were comparing between Nigeria, India, and UK, Sweden, and Denmark. That might reflect some people who are critical. They might say, well, this is related to psychosocial problems rather than to the medication that you are giving to the patients. People in developing countries, they are more closed family. People in developed countries, they are highly critical of the patients, and because they are expecting these patients to be part of a productive community, they are going to work. And this where sometimes we might lose some points in this kind of challenge. I worked in liaison psychiatry in this general hospital, and I have reviewed, following the request from the team, 264 patients. And this is the distribution of the clinical findings following my assessment. And as you can see, there is 11% of this sample have been presented with psychotic symptomatology. And that means psychosis, they are present on the ground. They are part of our clinical work, and we need to deal with them in an effective way. طبعا, as you know, prescribing antipsychotic for psychosis, and sometimes we prescribe it for out of license. The psychosis based on the first rank symptoms and second Schneiderian symptomatology. There is a tendency nowadays to have a unitary diagnostic entity. And I think it started to expand now, despite all the ICD-11 and the DSM-5. And I will come a bit later about the way how we are operating in my team. But definitely, as we know, the first rank symptoms, they are pathognomonic of schizophrenia. And these are based on the passivity phenomena, the perceptual disturbances, the delusional perception, primary delusions, and also the presence of the second Schneiderian symptoms like the catatonia, the delusional system, other hallucinatory experiences. So these are where we prescribe the antipsychotic. But it's not only that. We know that we prescribe in bipolar affective disorder, in mania and psychotic depression. There is a persistent delusional disorder, also as a separate or independent entity. Sometimes we prescribe some of the antipsychotics, especially in rapid tranquilization in patients, in severe agitation, restlessness, aggression. There is a huge number of people with personality disorder, especially with the borderline personality disorder, and they are on antipsychotic, despite all the recommendation not to touch antipsychotic with this group and use psychotherapy, but never works. We end up prescribing some antipsychotics. OCD, when it's really severe and complicated, we end up prescribing antipsychotics. Post-traumatic stress disorder, the same. Delatour syndrome and Huntington chorea and Parkinson's disease, all these kind of neurological disturbances, they end up with psychotic symptomatology, which requires psychiatrist intervention and assessment and prescribing some drugs. What I want to say really about the drug-induced psychosis, that there is a recent meta-analysis by Dr. Marconi in Italy. It's a very big study, and he confirmed during the meta-analysis that 15% of schizophrenia cases in young males, they can be prevented by avoiding the use of cannabis. There is a number of colleagues nowadays worldwide. They are confirming that cannabis is a good drug to use in physical health problems, in comorbidity, and mental health. But the fact is that we have seen a number of young male patients suffering of schizophrenic patients following the chronic use of cannabis. We know about the negative symptomatology. If any patient present with early negative symptomatology, the prognosis on long term is worse. And negative symptoms, everything in terms of functions, as we have seen in the mesolimbic kind of system, there it's reduced. So we have the volition is reduced, the affect is reduced, the movements, the eye contact, and some patients, they might end up with negative symptomatology as a primary problem, like in catatonia, if it's presenting. We used to call plenty of negative symptomatology in the 60s and 70s of schizoid personality, which it doesn't exist anymore nowadays, and simple schizophrenia. Now there is the ASD, it's coming into light, where we have identified some kind of psychopathology with this group of people who are presenting primarily with autistic features. As we know, the antipsychotics, they can be classified as first generation of antipsychotic and the second, or typical and atypical, or pre and post 1990. But to be honest with you, all these kind of three classification is not right, mainly because we know one drug of the second generation, clozapine, has been around in the late 80s, 90s, maybe before. And the the extrapyramidal side effects classification of the first and the second, they are present also in the second generation of the antipsychotic. And the same, we need to bear in mind that each drug is different from the other, and we need to be able to identify the patients who will improve on specific drug rather than specific classification. However, saying all of that, the first generation of the antipsychotics now, they are used less than before. We use more of the second, based on the fact that when we used, I remember when we used to go to the clinic in the early 80s and 90s, we used to recognize the patients by the way how they were walking, to recognize even that we didn't meet them before. The way how they walk, we used to know the patients. The evidence of the painful kind of acute dystonia, which we will talk about. This is part of the new antipsychotic or the atypical antipsychotic. And as you can see, there is the oral and the long-acting injection. And I would like to junior doctors to be aware of the fact that there is very often we hear, especially the nurses saying depot injection. Not all of them, they are depot injection. We refer to a specific category of depot, the other one long-acting injection, and there is the difference. It's the depot injection, they are oily injection. These ones, the long-acting, they are aqueous, water-based injection. And this is why they are administered deeply in the muscles. And the olanzapine imponate, for example, can cause postural hypotension and cardiovascular problems if it's injected directly into the bloodstream. This is why we have the post-injection syndrome, where the patient needs to stay in the clinic, not to leave the premises for 3 hours. And a qualified nurse needs to check the blood pressure and the vital signs every 15 minutes for the first hour, and then every half an hour, and then to check before they leave, while a doctor is present in the building in case of any problem might arise. I heard some colleagues might administer the Abilify Mantina or the Xeplion, paliperidone injection directly as a first prescribing medication. In UK, it's not allowed to do that, unfortunately. You have to start the patient on oral medication, especially risperidone, for a couple of weeks to confirm the benefit of the medication, and then to start them on the long-acting injection, Xeplion. And then there is the Trevicta, which is once every 3 months. So you will have 4 injections in a year, which is a good, really progress in terms of medication. May I just mention about the clozapine? Clozapine is a very good drug, and we have seen a number of patients, they improve dramatically, especially young students at the university. They return back studying. Clozapine, despite the fact that the good as a good medication, but it has also serious adverse effects. When we identify the people or the patients for clozapine as treatment resistant in schizophrenia, we have to ensure and document that they have tried 2 other antipsychotics previously and they did not improve. This is why we start them on clozapine. But let me just share one experience with you, if you allow me. I had a patient who was at the university. He was 19 years of age, and he was studying in Hull University. He became unwell while he was studying. I think he was in first year, 19 years of age. He was smoking cannabis also, but he was fluidly psychotic. He was not sleeping in his bed. He believed that there is a conspiracy, people coming inside the house and they are going to kill him. Anyway, his parents, they went to the campus and they brought him back. And they brought him to us. We have seen him, admitted him to hospital. He was actively suicidal with, we knew that from the start. He was treated with risperidone medication. On the second week of his admission to hospital, he managed to hang himself in the bathroom while he was showering. I have attended the coroner's hearing, which was very, very painful, honestly. And his family, they brought an independent psychiatrist to attend the coroner's inquest. And one of the things really which I learned from that experience, which I have been asked, why you did not consider clozapine as a first drug treatment in this patient, because you knew that he was actively suicidal. And this is valid, to be honest with you. I I think we need to be flexible. These are guidelines, but at the end of the day, it's our decision. When we choose patients for clozapine, definitely they need to go through the physical examination and blood tests. We need to ensure that they are ready for this medication. One of the things which I have also learned about the benign neutropenia, you know, if there is leukopenia or granulocytosis is becoming a dangerous drug. And if the white blood cells drops down, that means it's becoming amber and then red. And if it's amber twice, the medications should discontinue. If the white blood cells below 3,000 or 3 multiplied by 9, that's becoming red, and that the medication should discontinue. But I had a patient who had amber a couple of times, but he was fine. There was no evidence whatsoever of any infection or any kind of discomfort, or he was fine. So I was wondering what was going on. So I contacted the hematologist in the clozapine monitoring service, who advised me to contact the hematologist in the general hospital, which I did. And they have seen the patient and they have done the differential of white blood cells. And they have confirmed that it's benign neutropenia. And they have given him the GCSF, which is granulocyte injections once every 2 weeks for a while. And the patient kept on clozapine and he was fine. So it's not always that when we have the amber or the red, it's absolute contradiction to the prescribing the clozapine. The other thing is I have a patient on clozapine and lithium. Lithium can increase the white blood cells sometimes, and this might really help to ensure that the results will come green. The evidence-based, the evidence-based that definitely there are evidence that the antipsychotic medications, they improve the clinical picture of the patients. There is a study of 510 people with antipsychotics. They classified them into groups. 156 patients never taken antipsychotics and 354 treated with antipsychotics. They have seen that the 57% of the treated group were in complete remission or partial remission, while 30% of the untreated group, they are in complete remission. That will indicate that the antipsychotic medication, they are working in patients with psychosis. Again, in 1962, Philip May studied 228 patients with first episode schizophrenia, and they classified them into 5 different groups. People have taken ECT and antipsychotics, people on psychotherapy. Some of them, they were on drug and psychotherapy, and some of them on psychosocial intervention only. And they found that they maintained people well for 12 months without acute relapse or without readmission to hospital. The highest people who have been well for these 12 months, the people who were on drugs and psychotherapy together. But the people who had the psychosocial intervention, they were the worst group. people for 5 years who have been maintained well, who had ECT and drugs at the same time. And that indicates in that particular time, we are talking about the 60s, where ECT was common in schizophrenia. In the late 90s, I was involved in this study, which is sponsored by Eli Lilly. We had for 3 years, 36 months, we were 2,000 doctors from Europe, from UK, Greece, Italy, Spain, and we had 10,000 patients or more. They were selected. And these patients, just clinically, they have switched between the first generation and to olanzapine. Definitely, we had specific kind of regime of intervention based on CGI, the clinical global impression, where we have done it after 6 weeks and then 12 weeks through all the study, and we identified the outcome based on specific kind of interventions related to their improvement. And we compare the people who have been on first generation antipsychotics and the second generation, including the side effect of these medication. What we have really came out, as you can predict, is Eli Lilly in that time were looking to produce the olanzapine Zyprexa. Patients treated with olanzapine had higher weight gain than other patients. And the results of the SOHO study indicate that the difference in effectiveness and tolerability do exist between the antipsychotics. So it's not only one drug or the other. You need to be able to identify the patient for specific drugs. This is when we have been invited to attend one of the conferences by Eli Lilly. This is in Tenerife. We had a few days there, and you can see I'm there in the middle. Now, I work in early intervention psychosis, or we call it PATH. And the team in the area where I work, it's divided into 2 groups, North and West. And I do the North. And in the team, we have, you know, the nurses, they are bands. We have band 6 and band 5 and band 4. Also, at the same time, we have associate practitioners who are trained in psychosocial interventions and slight psychotherapy interventions, mindfulness, anxiety management. Yeah. And all of us, we work as a team. Each patient will be seen by me during the course of the assessment. The mini team, as we call it, mini team, the group will do the bands and the COMS, which is the positive and negative scale, and also they do the comprehensive assessment for psychosis. There is a subgroup of 2 individuals who are working with me towards identifying arms, which is at-risk mental state. We have 6 patients of them. And these patients, mostly they are 18 or 19 years of age. And they come with emotional disturbances, emotional dysregulations. Very often they claim that they hear voices, seeing images, shadows, which disturbing their quality of life, really. And we are working with them with the support to their family. They use the education as part of their intervention. And as I said before, we use to avoid the diagnostic uncertainty about this group of patients, we use unitary kind of diagnosis, which is based on first episode psychosis, we call it. Yeah. Definitely during the course of the assessment, we identify the untreated period of psychosis because this will light the prognosis on long term. And we try to reduce the relapse rate and the readmission rate and sustain the professional involvement during critical periods when the patients, they are under exam pressure or family dynamics. This is that's the team. As I said, I have 82 patients on the book. Definitely, I might see the patient once every month or some once every 3 months, but definitely weekly they will, or fortnightly, they will be seen and contacted by the other mini team. The psychologists, they provide CBT psychosis. Also, we have an individual comes from background of employment advisor or employment service, which provide an assessment to the patient, helping them, supporting them during preparation for the CV for work, finding sometimes employment for them. We focus on the physical health as part strategy of the trust that we are working in. And we do the physical examination for the patients when they are referred to us. And we do blood tests. And I communicate with the general practitioners regarding the findings, if there is any abnormality. And very often, honestly, we find some patients, they come with high cholesterol. Sometimes the HbA1c, it's more than 47. So there are some indications that they might be susceptible to develop diabetes type 2. And this is extremely important to identify that. Let me just tell you about one case I have been involved in. This is a 52 years old lady. She was unknown to psychiatric service before. She has three children. The screen here covers I can't remember everything, to be honest. There is no alcohol misuse or any illicit drugs. She was working in a factory nearby. On the 12th of September last year, she attended A&E with some friends, and they were complaining that she is very disturbed, she's not sleeping, and she's searching for her 3 children as if they are around and they are lost. So they have arranged for a mental health act assessment, but definitely after the assessment, she was referred to the crisis intervention team. So they let her go back home. 2 days later, her condition deteriorated further because she invaded the neighbor's house looking for her children, searching for them as if they are hiding, these neighbors hiding the children. So the neighbors, they called the police, and the police brought her to under section 135 for an assessment. And she was admitted to hospital later on under section 2 of the Mental Health Act. And she had a delusional system that the people, they are preventing her of having access to her children. And she was very disturbed, very agitated, very restless, very stubborn lady, African lady. And she was protesting against her admission. She stopped eating, not drinking, refused to talk, refused to cooperate with the staff. She was sleeping in the lounge in fear that if she will go to sleep in her own bed, someone will assault her. She was prescribed the olanzapine tablet, but again, she refused to take it. On the 18th of September, which is around a week later, she became very dehydrated. She went to General Hospital and she had IV fluids. But again, there she handcuffed by the police because she was uncooperative and she was administered IM medication, or olanzapine, sorry. On the 21st of September, she returned back to the psychiatric ward from the General Hospital. And on this occasion, her personal hygiene was very poor, refusing to wash herself or change her clothes. She became very uncooperative, mute during the ward round. She doesn't want to talk. And she did not eaten or spoken to the team for a few weeks, really. And she was asking to leave her, go home. At this stage, and we are talking about after maybe 16 days of admission, they started her on depot injection, which is the flupentixol decanoate. We need to bear in mind that she had olanzapine IM injection just a week before. The blood test showed that she had high cholesterol, 8.2. And on the ECG, she had tachycardia, sinus tachycardia. And there was a lump during the physical examination around her thyroid gland. She had no idea of her physical health in general, really, what's happening. Her legal status in the ward switched into Section 3 after an assessment. And on the 4th of October, she received flupentixol, Tipixol, 40 milligram IM fortnightly, and 10 milligram of olanzapine. She developed electrolyte imbalance, and I think she had hypophosphatemia, or magnesium was low. After 15 days of complete starvation, I think I need to say here that there was another African nurse in the ward, and she invited her to eat her own food, the nurse food. And that was a very, very good gesture, really. So she started to share the food with the nurse, and she started eating after 15 days of starvation. And there is no doubt that the medication had made some kind of implication on her improvement. On the 3rd of 11, she received flupentixol 80 milligram. So she had 20, 40, and 80. On the 5th of 11, some improvement, resolving the psychotic symptomatology. She started to say that, yes, I'm not sure if you are stopping me, but they are around. I will look for them, something like that. So started to make the things not of a delusional system. Her son, in fact, arrived in that time from Africa to visit his mom after they have informed him. And on the 14th of 11, Section 17 leave has been granted to her, and she went home for the weekend.
Dr. Amin, 5 minutes. Yeah.
Really? Oh. Anyway, she had flupentixol 160 milligram a bit later, and then her condition deteriorated rapidly with after the visit of the nursing staff. She was described as robotic, stiff, unable to talk, unable to walk. I went to see her at home. They stopped all the antipsychotic medication, but she had, as you know, the depot injection. I have visited her at home in that time. When I saw her, she was communicating reasonably well. I did not really feel that there is any immediate risk to her life at all. There was no evidence of hemiparesis or paralysis or anything like that. She was not feverish. I stopped the antipsychotic medication and I left with my colleague, the nurse, who have visited her. 15 minutes later, exactly, she collapsed and she died, this lady. Yeah. The information that we had that she died of a cardiac arrest. Yeah. This is Letchworth, just nearby here. And you can see this is the first roundabout in UK. Some people say is the second after a roundabout in Chicago. And this is in 1909. The second case from Letchworth is a lady who I have seen and started her on olanzapine in the community. In the weekend, she became more disturbed, admitted to hospital over the weekend, and her medication changed into haloperidol and risperidone because of her husband did not believe that she improved on the olanzapine. And then she stopped talking, stopped walking, stopped any movements. She was feeling sick for 4 days, drowsy, withdrawn. She had a feverish 38, unable to drink or to eat, febrile. Admitted to ICU in that time, and all the medication stopped. There was some inquiry if she's in catatonia, or I went to see her. She had white blood cells. The CK was high, very high, as you can see. Identified neuroleptic malignant syndrome. She was treated with lorazepam, dantrolene, bromocriptine. She had tracheostomy in that time also. 3 weeks later, I went to a professor who had some experience in situations like this in Hatfield, and I brought him with me. We have seen the lady in the general hospital, local one, diagnosed her with lead pipe syndrome and treated her with procyclidine 60 milligram IV in the drip slowly with diazepam. And she started gradually to recover. And she recalled all the events, all the discussion that we had during her state of lead pipe. She was fully conscious, but she was unable to talk or to move her body. 2 days later, she developed PE, pulmonary embolism, and sadly, she died. This is the look-in syndrome. As you can see, the patient can't speak, they can't produce any movement, they can't chew, they can't swallow. But they can move their eyes up and down, they can blink. In fact, sometimes she was communicating through her eyes. They can hear, but they can't speak. And this is why she was recalling all the things. The antipsychotics, as you can see, we know very well that they have the extrapyramidal side effect of dystonia. Is very painful condition. It can be with torticollis sometimes, and we can treat this condition with procyclidine, IM sometimes. Pseudo-Parkinsonism, akathisia is very, very interesting phenomena in patients where you can't see, they describe it to you. And very often, because of the restless legs during sleep, can lead into suicide. Tardive dyskinesia, as you know, it's one of the irreversible complications of the antipsychotic, long-term antipsychotic medication.
Time's up.
I have a few slides just to finish. Is that 3 minutes?
5 minutes, okay.
Okay. Neuroleptic malignant syndrome, as you know, the incidence is a bit over nowadays because of the that we believe the second generation of antipsychotics, they are immune of these side effects. In fact, we had cases with olanzapine, we had cases with aripiprazole, so we need, the mortality rate is very high. The risk factors, especially in hot weathers, like in Jordan or in Middle East, we need to be careful about people taking antipsychotics and become dehydrated. We need to check the electrolyte imbalance, the agitation. Also in catatonia, patients might develop this condition. If there is a history of neuroleptic malignant syndrome previously, the complications, the rigidity, I think we need to focus on two things. The thermoregulation is very, very important, especially not always. If somebody takes analgesics and they have an MS, we can't really see if they have a fever or not. So this is very important. Also, at the same time, the movement disorder. There are specific kind of conditions nowadays in USA. They do dialysis to the patients when they develop this condition because of the renal failure and disseminated intravascular coagulation. There are some drugs which can use better than others, quetiapine, clozapine. Again, in MS, we have cases confirmed with lithium and antidepressant. Illicit drug abuse, people usually, they are ignored in these kind of conditions, but it can kill them, definitely. And the history of catatonia also, it's important to distinguish the presentation between NMS and catatonia. Just about the serotonin syndrome, there is a lot of similarity. However, the serotonin syndrome, the onset is quicker than NMS. The neuromuscular kind of findings in serotonin syndrome, they are agitated, hyperactive. Sometimes you might see them with choreiform disturbances, but in neuroleptic malignant syndrome, they are rigid. They recover if they are lucky from serotonin syndrome within days, but in neuroleptic malignant syndrome, it might take a couple of weeks. The ECG changes sudden death due to neuroleptic malignant syndrome. It's very common also in this kind of condition. We need to be careful about the potassium and sodium and calcium channels in blockade of the cardiac conductive system. Sometimes the patients might receive the depot injection and then they will have ventricular fibrillation and they die. So it's important, especially with the clozapine, cardiomyopathy is common. Hyperprolactinemia, as we know, it's very common in patients taking amisulpride, taking risperidone. We need to elicit, it's asymptomatic, definitely, but also at the same time, if it's becoming chronic, there is irreversible problems might happen. So it's better to deal with the problem. Honestly, I had a number of patients where they improved dramatically while they are maintained on paliperidone. Just give them a small dose of aripiprazole, small dose, 2.5 or 5 milligram, concomitant treatment with the paliperidone, they improve on it. Prescribe antipsychotics when it's appropriate. Avoid antipsychotic polypharmacy as much as we can. Try to focus on the QT interval and prolongation to assess if they are at risk. Definitely we need to do ECG. The patients, when they are naive to antipsychotics, I think we need to be very, very careful how to prescribe the medication and to gradually increase the dose. Yeah, these are the references. And lately, Dr. Walid, if لو سمحت لي يعني طبعا الغربة صعبة، ولكن هناك في link between الأدب والشعر والفن. في أحد زملائي بيشتغل معي بيعزف على الفيولين، وهو كونسلتنت معنا، لكن بروح بيعزف على الفيولين. فهاي القصيدة هذه لكم يعني لمحمود درويش.
شكرا جزيلا دكتور أمين على هذا العرض المميز والمعلومات الوافية. نفتح المجال للتعليقات والأسئلة. دكتور نزار.
شكرا دكتور وليد دائما على هذه السلسلة من المحاضرات، وشكرا دكتور محمد أمين الحيحي على هذه السفرة الجميلة اللي أخذتنا معاك بها خلال هاي الرحلة. For the sake of time, I will mention only 2 or 3 very quick comments. The first one was for Parkinson's disease. As you know, nowadays, if it's available, we don't use antipsychotics. We use pimavanserin for cases of Parkinson's disease to avoid decline in cognitive function. And some of the antipsychotics, as you know, they have extrapyramidal side effects. For that reason, if it's available, pimavanserin is the best to do. The second thing is, among the psychotic symptoms that you've mentioned, nowadays we have an entity called secondary negative symptoms. They are not actual negative symptoms. They are negative symptoms induced by drugs, or, as you correctly mentioned in one of your slides, it's a case of severe depression. When you treat the cause of the secondary negative symptoms, the patient improves and gets better. The third one, you correctly mentioned the use of long-acting long-acting injections of antipsychotics. It's because some of the authorities, some of the psychiatrists believe that once you have one episode of psychosis, first onset of psychosis, if you don't treat it properly and if you give the patient time not to comply with the medications and have a second episode of psychosis, then it will be almost impossible to treat that patient. For that reason, they recommend the use of long-acting injections from the first episode of psychosis. I personally do not agree with that, but this is what was published. The last thing is I want to really share with you an incident of prolactinoma that occurs in one of the patients, male patients that I have treated with risperidone. He developed a lump under his breast, and it was very difficult to treat. I don't know what happened to the patient, but usually you need surgical intervention to treat that condition. And I repeat, thank you very much for this nice journey with you.
Dr. Sadad.
شكرا جزيلا على هذا العرض الشامل للأنتي سايكوتكس أو مضادات الذهان. في الحقيقة يعني كان العرض شاملا لما تاريخ العلاج. هناك في بعض الإشارات إلى استعمال مختلف العقاقير في مختلف الحالات، بس فقط أحب الإشارة إلى WHO study اللي 1979 اللي كثيرا يعني people reference that quite frequently. But unfortunately, I mean, if we look back really at this study and critically evaluate it, I don't think it would have been published now. I mean, they relied on the diagnosis of schizophrenia based on blurrier symptoms. I mean, I don't think this is really a very good diagnostic guidelines to diagnose schizophrenia. And as a result, there has been this impression that the outcome of schizophrenia in the third world is better than in other countries and so on. But I have to admit that the criteria used for diagnosing schizophrenia are highly suspect, also the control and so on. I've said if it is, they presented today to a journal, I think it will be critically evaluated and maybe it will not be published. The second thing, we have to accept that really, I mean, antipsychotics, yes, they have limitation. And there is a very good study that really outlined that even with people continuing an antipsychotic, patient with schizophrenia would relapse within 5 years of onset of the first episode. And the reason for that probably due to the issues with under or hyper regulation of the dopamine receptors. Still, at the end of the day, we remain paralytic in the fact that we always aim at something as good as a clozapine. And I think we still struggle with that. And we still think, well, clozapine is probably the best treatment. And we have to recognize that the chances of people getting better on a clozapine or respond to it approaches 80% if it started within 18 months of diagnosis, and it drops to less than 35% if it started after 2 years of diagnosis. But thank you very much indeed for reminding us all about these antipsychotics, their side effects and their indication. Thank you very much indeed.
شكرا دكتور سداد. نسمع إذا في أي سؤال من الحضور. Any last comment, دكتور أمين؟
نعم. First of all شكرا جزيلا على يعني أنا أعتبركم أساتذة بالنسبة لي، وهذا شيء جيد يعني إنه إحنا نتشارك ونشير this experience together. بالنسبة للباركنسونز ديزيز دكتور نزار، يعني طبعا شيء جيد إنه ما نعطي الباركنسونز patients antipsychotic medication. بس الحقيقة يعني من خلال عملنا أو هاي إحساسي أنا، يعني مرات بنحس إنه النيورولوجيست نفسهم لما يكونوا في وضع غير قادرين على مساعدة المريض بيحولوه للسايكاتري، وهذا اللي بصير يعني. ولما المريض يجينا طبعا his symptomatology might attract us يعني to assess the situation and prescribe. Definitely, we are fully aware that prescribing antipsychotic in Parkinson's might worsen the condition, but we end up under the pressure of the carers, of the family, of the patients themselves. We end up prescribing antipsychotic in small doses, definitely. And as you know, when someone has Parkinson's disease, they are going into an old age. So there are significant problems related to the antipsychotics because of postural hypotension, falling down, these kind of comorbidity might happen. but I share your feelings about the secondary negative symptoms, especially if it's related to a primary psychiatric condition like depression. And we know that from the clinical practice that sometimes patients, they withdraw, they are not interested in their surroundings, they lack initiatives, all these kind of things, they are presenting as part of the depressive disorder, but they look like secondary negative symptomatology. حضرتك كمان حكيت عن البرولاكتينوما. احنا لما نعمل البلاد تيست طبعا بيجينا الريزلت الان الكترونيك يعني، فدائما بيذكروا يعني there is no evidence of prolactinoma there, or it's not indicated to investigate the prolactinoma even when we have the prolactin blood level around 4,000 something. So it's high, but definitely the blood form or the blood test doesn't really make us any kind of indication that prolactinoma can. And definitely prolactinoma, we need to have access to the brain, or we need to have an MRI scan, or some indication needs to be there to, I don't know, what's your comments about that?
First of all, I quite agree with you regarding the Parkinson's disease. In fact, by the prolactinoma, I didn't mean in the brain. It was a male patient who had a lump in his breast. This is what I meant. There was a tumor in the breast as a result of the use of antipsychotic.
Okay.
This is what I meant by the prolactinoma.
Right. Thank you. I got you.
شكرا جزيلا دكتور أمين. شكرا.
Can I just, Dr. Walid, just 2 minutes to Dr. Jawad. حضرتك تفضلتوا عن موضوع ال WHO study between developing and developed countries. Definitely, there are some subcultural issues related to the findings. I believe in that. The expressed emotions في بلادنا is different from the expressed emotions في الغرب, في الوest. The other thing, the duty of the individual, it's different. You know, in the West, when the individual reaches 18 years of age, they are independent and they need to deal with their life. They need to get out of the house, the parents' house, male or female. That's the reality. How is it? In developing countries, most likely the extended family take this responsibility, and they end up dealing with the patients in the way how they believe is right, which most of it is wrong. We know that. So, and this is what I think they meant, the WHO findings, that the people, they are better because they smile and they are living with the family. But I agree with you completely that if the study is done now, yeah, the story is different.
Thank you very much. Thank you.
Thank you. شكرا جزيلا مرة أخرى. شكرا لهذا التقديم وللحوار. نلتقي بكم بعد أسبوعين إن شاء الله. إلى اللقاء.
شكرا. مع السلامة.
مع السلامة.
مع السلامة.